Ultimate Health on Joy 99.7 FM. Let me catch my breath. Some old school praise, huh? 1978, The Rivers of Babylon. All the way back to 1978. When we remember and Mega Banger, my praise for today. Stick and stay with me. Ultimate Health on Joy 99.7 FM. Listen every Sunday, 2:05, we come alive by His grace. My name is Nortey by nature. And we're still on brain stuff, right?
It's another OPK classic.
Neurological disorders. We've been exploring, unmasking, and bringing epilepsy out of the shadows. If you have any questions, concerns, WhatsApp is 055 11 11 997. We're live on Facebook and YouTube. We're continuing from last week. I'm honored again to have in my presence in the studio Professor Patrick Ajay, an associate professor of neurology, head of the Department of Medicine at the Kolebu Teaching Hospital, and we will be honored to learn at his feet. Any questions, concerns, WhatsApp 055 11 11 997. And shortly, I will activate the phone lines. Prof, you're welcome.
Thank you very much.
Great to have you again. We've lost Fifi.
He's up to some other task.
Right. But great to have you. And once again, many thanks and gratitude to the Neurology Society of Ghana for lending us these specialists in this extended, should I say, treatment, right? Dissection of brain-related issues. We've still got dementia coming up. Sleep is a big issue. The various types and forms of headaches. I don't know whether Parkinson's and other things will come in there, right? But we're grateful to the Neurological Society. Good afternoon, Professor Albert Akbalu. So, Prof, you're welcome.
Thank you very much.
Last week, we learned what a seizure was, an unprovoked electrical disturbance in the brain. We move forward to try to understand when it becomes conclusively a disorder of the brain, why there are many different types, and the kind of presentation or what actually happens or what we will experience or see during a seizure. Is there anything you want to highlight? I remember also that we did establish conclusively that you cannot catch epilepsy from anybody. It's not infectious, right? It's non-communicable.
Yes, I think we spoke a lot on that last week.
Yeah.
That epilepsy is not a contagious disease or contagion.
Right.
It's not something that anybody will get by holding me if I have epilepsy.
Okay. And then you also emphasized and highlighted things we should not do when somebody is experiencing a seizure. Can we just hit on those again?
Yes, exactly. I think we spoke about if someone is having a seizure and you are there, do not put anything into the mouth or force anything into the mouth. Because we spoke that if you force anything in the mouth, you can cause the teeth to dislodge or break. You can cause the tongue to be pushed backwards, and all these things can affect the breathing pathway and can lead to unwanted death or anything of that sort.
Right.
And the best you can do is help the person to lie down, or to lie down, and then if you can, fold a piece of cloth under the head so that the moving head doesn't hit the floor.
Okay.
Or if you don't have that, I would say luxury, you probably put your foot under the head so that your foot forms a cushion between the head and the floor.
Support and cushion the head.
Yeah.
Okay.
But do not restrain the person for any reason, because you can fracture the bones and that kind of thing.
Okay. And then we learned that typically this is self-limiting.
Yes.
It won't last too long, and I think we gave ourselves an upper limit about, was it 3 or 5 minutes?
Yeah, we said the duration of a TV advert, that's about 3 minutes.
3 minutes, right? Anything beyond that, then we should be vigilant and
sent to the hospital.
send the person to the hospital.
Yeah.
Okay, folks, I'm sure you remember many other things that we captured, but let me start the focus on treatment and management by asking, why should this be treated? If it's self-limiting, we seem to have an idea what it is. Why would a person require treatment?
Okay, that's that we accepted that it's a disease. So once it's a disease, we should treat it.
Okay.
And the tendency to have these unwanted events that the person involved has no recollection of can lead to several other issues affecting the person himself.
Okay.
And also the perception of the people around about what's happening to the person. If you've ever seen someone have a seizure, it's harrowing. It's difficult to look at. It's out of the world, really, to watch somebody have a seizure if you see it. So we need to prevent these episodes from occurring. In addition, we know that every seizure begets another seizure.
Okay.
So we know that every seizure that you have that is untreated can lead to you getting another seizure.
Okay.
So because it is believed that, it's not believed, we know that it has an effect on the brain.
Right.
And that leads to further damage that will lead to further seizures. So a seizure begets a seizure.
All right.
So we need to stop a seizure from occurring.
Okay. So you see why I asked that very, very, it sounds like a very irrelevant question, especially when you have a prof of neurology in the studio. But people tend to misunderstand. So uncontrolled, unprovoked, and therefore we have no means of predicting it, and therefore whatever damage it causes is also unmitigated. So there must be an intervention by way of treatment. Okay?
Exactly.
Right. Let's assume we've identified and conclusively diagnosed that this is epilepsy, or a form of epilepsy, or a form of seizure disorder we're dealing with. What are the options available?
Okay. Then we hammered on that one last week. Once you've been able to confirm that, or accepted that someone has a seizure, or somebody has epilepsy for that matter, and from all that we've heard so far, that seizures beget seizures, we get a perception of them people to you having a seizure. The healthcare professionals are trained to treat it as a disease.
Okay.
So epilepsy is a disease like hypertension that needs to be treated, and that's what we are going to try and discuss.
To break down.
Yeah, we have options. First is identifying the condition, which the healthcare professional will take you through. and then the use of medications to try and stop these seizures from happening. You've said something that we cannot predict its occurrence, but once we know that you have a tendency to have it, having had 2 episodes separated by 24 hours, then there's a increased risk of you having another one. So then we have these medications, tablets that we use that can reduce the risk of reoccurrence. So if you are moving from maybe 10 a week, 10 a month, these medications can reduce it to maybe even 0 a month for that matter. And then if these medications don't work, there are add-ons that we do. We have stimulation of the brain.
Right.
These are little electrodes that are stuck to areas of the brain or the nervous system, that when the seizures are happening, you've taken the medications are occurring and you're still having these seizures, then these stimulating electrodes can help control the seizures.
Okay.
And if all fails, you've had a stimulation, you've had your medications, then the concept of epilepsy surgery comes in.
Okay.
And the epilepsy surgery is a specialized, highly specialized surgical procedure that is done in many of the developed world, including India,
right,
where abnormal areas of the brain are removed to try and control the seizures.
Okay, right. If you've just joined us, it's 16 minutes past the hour of 2 on Joy 99.7 FM. The program is Ultimate Health, your ultimate guide to healthy living with me, Nortey by nature. I'm speaking with Professor Patrick Ajay. He's an associate professor of neurology with the Kolebu Teaching Hospital and the University of Ghana Medical School. He heads the Department of Medicine. He has a whole long CV, but he cuts all that short by driving here on a Sunday to share and educate. Essentially, we're looking at educating, empowering, informing people because, and primarily because, many of these seizures will occur in the presence of untrained non-professionals who must know what to do, who must have an idea of what is happening, and therefore take deliberate, conscious, decisive action. So that's why we're educating you. We're not turning you into professors of neurology at all. So don't go arguing at beer bars saying you know this and that, right? We're trying to equip you. But any questions are welcome. 055 11 11 997. WhatsApp, I see you. Oye Nafienya, welcome. And shortly I will activate the phone lines. We're live on Facebook and YouTube as well. Let me break them down and come to the pharmacological treatments or the medicines you talk about. So these are, well, anticonvulsants or anti-seizure medications. You say they are trying to reduce frequency ultimately, but what do they really do to the brain? If there's an unprovoked electrical charge and you administer medication, what essentially are you expecting them to do? I know a lot of patients seem to think many medications make them sleep, but what is it trying to do?
Yes, I guess you said a very useful term, the anticonvulsant, anti-seizure.
Right.
As the understanding of epilepsy becomes more clearer, and as we move from the societal perception of the disease, what we call the perceived stigma as well. So the term convulsant is believed to have a bit of negative connotation. So we want to focus on using the word anti-seizure because we have reached a level in society where we've come to accept that everybody is allowed one seizure in their lifetime. So we all can have a seizure. So if we have an anti-seizure medication, that's what it is. But these are medications that have been developed over time. Like I said last week, we have over 26 medications available, and you can have a medication that can match every letter of the alphabet.
Right.
So we can have from A to Z,
right,
and more. So what these medications does is that since we said they are abnormal electrical discharges, what they tend to do is they work on the brain to try and reduce or control the abnormal electrical discharges. And that is what it is. So for this platform, I think we'll use that explanation. And why they can affect your level of alertness or make you drowsy is because any medication that works on the brain may have a tendency to slow the brain down a bit.
Okay.
Yes, but these are some of the effects are more transient than persistent.
Okay.
So initially, if you start the medications, you may have these slowing of function of the brain, but as you keep taking it, the brain readjusts and adapts to the new environment. These are simple, basic things that can happen.
Okay.
So we do encourage that if you are diagnosed with epilepsy and your healthcare worker puts you on an anti-seizure medication, you should be encouraged to take it as has been directed by the healthcare worker.
Okay.
And that is what
All right.
I can say now.
Now, many people will listen to us, and many of our discerning listeners and many of our inquiring listeners can look up some of these things. And in some places, in some jurisdictions or practices, they have access to some of these medications, right? Obviously, there are certain criteria, certain indications that would inform your choice of a medication for a particular patient. Right? Can we look at some of these things? Are you just giving, because it's a seizure, are we giving medications? I want listeners to understand that this is a specialized territory, right? But I do know that people do have access and do repeat prescriptions over time. What would inform your choice of medication for a particular case?
Oh, several. Several. As with the healthcare practitioners, like I want to say here, they have studied these medications and they know the indications and risks associated with the use of them. And they know that we also know the type of seizures or the type of epilepsy that certain drugs are more effective on. So that's the reason why it should be initiated by a healthcare professional, and then it should be monitored frequently as much as possible. And so, for instance, there are drugs that we found. For instance, for a pregnant woman having seizures, you don't want to use certain medications, certain anti-seizure medications on them because it may have effect on the unborn child.
Right.
So those things are known by the healthcare practitioners. And so if you're a pregnant woman and you have seizures and you get pregnant and you keep your baby, you should see your healthcare practitioner regularly because there are certain medications you don't want to use. For instance, you have a stroke and you're on several medications working on trying to help your stroke improve. You wouldn't want to be on certain medications if you do have a seizure. And all these things, the healthcare practitioners are equipped to work on that one as well. Elderly people, you don't want to use certain medications which may further compromise their situation. So you may see your healthcare practitioner who may evaluate and put you on the appropriate medication. So, and even if you're on a blood thinner, there are certain anticonvulsants or anti-seizure medications that you shouldn't even use at all. So those are some of the nuances that go into the prescription of these medications. And most of the healthcare practitioners would know what to do. So you need to see your healthcare practitioner. And these things have to be monitored. And these medications, too, apart from working on the brain and having all these effects, may also have an effect on your kidneys, your liver. And so if you have a liver disease, there are certain medications, anti-seizure, that we may want to prescribe for you. All these things we are abreast with them, and we do it appropriately and accordingly.
Very well. 24 minutes past the hour of 2 on Joy 99.7 FM. We are increasing our knowledge, our awareness of the issues, should I say, features related with epilepsy, courtesy of our discussion with Professor Patrick Ajay here in the studio. Shortly, I will activate the phone lines. We're live on WhatsApp, 055 11 11 997. Evergreen, Linda Inosu, I see you. I see other people typing. We're live on Facebook and YouTube, and we are, dissecting brain disorders, neurological disorders. I asked a question about the considerations that would inform the choice of medication, right? But I'm asking a professor. I'm asking a person with the requisite experience, qualifications, and so on and so forth. If something could go wrong, he or she or whichever professional would know that. I know many of you listen to this program and immediately shoot off questions to other practitioners or other professionals. So that's why I try to align these questions. Okay, so Prof, we would expect with this kind of pharmacological intervention that, well, there would be some impact on the seizures or on the unprovoked seizures. One of the indicators or indexes you mentioned was frequency, the number of seizures you get within a given span or spectrum of time, right? But I'm sure there are other indications that you'll be looking out for.
Exactly.
Yeah, because last week, the reason I'm asking, last week we had a caller who you encouraged to see either of you or both of you, right, who was a bit frustrated at what he reported as lack of response or lack of change, even though his son, I believe, had been on treatment for quite a while. I think it was in relation to drug treatment, and then we made some comments, right? But the layperson would probably be thinking, well, I've been taking it for some time. I am not aware of any change. That's why I'm asking this kind of question.
Oh yes, that's what I'm saying. Like we said last week too, you need to see your healthcare practitioner if there are any issues with any drug you're taking and you are not getting the response. And the same with the anti-seizure medication. So if you are on anti-seizure medication and you're not getting response, it has to be discussed excessively with your healthcare practitioner, right, or the one who prescribed it for that matter. Because like I said, there are several drugs. If one drug is not working for you, another drug may work. And we also are able to monitor the levels of drug within your system.
Okay.
There are certain people that certain drugs within them are removed quickly than the others. So if you're able to monitor the levels of the drug within the system, in the person, you're able to see that, okay, so if you are on 100 and it's not working, I could use maybe 200.
All right.
If it's on 200 and it's not working, because of the way your body metabolizes the drug, I could use a higher dose.
Okay.
Or the dose that you are having is giving you more side effects than good, then that drug can easily be changed and you'll be put on another one.
Right.
So the thing is, we have a whole huge armamentarium of anti-seizure medications to try.
Okay.
We do have a little bit of challenge when we are working locally within in the constraints of our healthcare system. Because of all the 26 medications, only a few really are readily on the National Health Insurance.
Okay.
So then we are limited with our choice. But even within that, what we know is that the older drugs and the newer drugs, the efficacy between the two, between the sets are not that much really.
Okay.
It's just that the older ones may have a little more side effects than the newer ones. But whatever situation that you are in regards to the drugs, you need to see the healthcare practitioner so that they can vary, add on, change, and suggest ways forward.
Okay. Right.
Even in the care, even without anti-seizure medications, because of the stigma, many of our cases may have a certain level of depression within them, and that depression may further fuel reoccurrence of seizures. So in certain situations, having a mental health practitioner involved with the care improves the seizure reoccurrence and outcomes.
Oh wow.
Right. So it's not that simple, and there's enough evidence that epilepsy is associated with a certain level of mental health dysfunction.
Right.
Yeah.
Okay. When you hear me saying, oh, wow, right, I'm doing it on your behalf. But I'm sure you fully appreciate what Prof is sharing, right? So there are many things that will become proxy or maybe even primary indicators of how you're doing and the degree of management that is being achieved with your seizure disorder. This one says, it's from Mike Inungwa. Hi, Nortey and Prof. A friend had a brain injury or brain tumor and got removed for some time now at Kolebu. She's been experiencing seizures even after the surgery and has been put on Keppra for some time now and every day. I want to know if the drug is to cure and do away with the seizure or what. Oh, Mike. Is she going to be on Keppra for the rest of her life? Okay. Mike, you bring in so many scenarios. Prof and I are smiling and giggling a bit. But Prof, just a quick comment on this. So this person had neurosurgery for tumor, and post that surgical intervention, she's experiencing seizures. She's been put on something which he's aware of as a friend, and he's asking questions.
Oh yes, his questions are quite legitimate,
Okay.
Mike. Once she's had a brain tumor which has been resected from the brain, for instance, it has left a scar on the brain itself, and that scar now becomes a source of possible seizures. And so if you look at it from that angle, we'll say that there's a scar in the brain, and that scar is the source of the seizures.
Yeah.
So that person is at risk of seizures for a long time. I don't like using the word for life, really, because
Right.
I don't give life, but for a long time. And in that situation, if she's on anti-seizure medications, it needs to be varied accordingly to try and stop the seizures from occurring. So if it's only on one medication at a certain dose, she needs to see her healthcare practitioner to vary the medications, to add on, and to try and stop the seizures from occurring. But what we can see at this now that she might be on medications for a very long time.
Right.
And it is to try and stop the seizures from occurring rather than, and if it stops, we say it's a cure in a way,
Right.
in quotes.
In quotes. Right. It's great you add that, because my late dad had a stroke, which required brain surgery. After that, and as a result of scar tissue, of course, there were post-intervention seizures, which had to be managed, right?
Exactly.
So whatever you did, you touched the brain has been touched, there was a result, right? And you mentioned the scar tissue, which is now causing the brain to misfire.
Exactly.
Okay. So, Mike, on behalf of your friend, I hope that has been dealt with. Benjamin Quarter in Westlands, please, what's the difference between a fit and epilepsy?
Oh, thanks. I think we spoke about that one last week. The fit is another term for a seizure, really.
Right. The actual event.
The actual event. And then the epilepsy is the disease, the tendency to have the seizures or the fits, for that matter.
Right. 32 minutes past the hour of 2 on Joy 99.7 FM. We're breaking down the treatment and management options for epilepsy with Professor Patrick Ajay. If you have any questions, concerns, I think I will activate the phone line 030-221-6541. 030-221-6541. You get to talk to a professor of neurology directly. Okay? Be nice. But do ask your questions. WhatsApp is 055 11 11 997. The program, as always, on a Sunday afternoon with me, Nortey by nature, is Ultimate Health, your ultimate guide to healthy living.
Joy 99.7 FM.
Right, so we've looked at this medication. I think it's worth going over. Last week you mentioned combinations of medicines as well to achieve the same thing. So you could be on more than one of these medications.
Exactly.
Right. Based on experience and knowledge that they work better, perhaps, or give you a better effect in combination.
Yes, well, based on the fact that combination therapy sometimes may increase the rate at which you can slow down the seizures.
Right.
And that kind of thing. So basically, that's what we do. If one medication doesn't work, we add another one. If two medications don't work, we may add a third one.
Okay.
And if after three medications and we are not achieving goal, then we are thinking of the stimulation, that brain stimulation, and the epilepsy surgery.
All right. Okay. So I'm supposed to take this accordingly, as prescribed. What happens when I miss my medication or I default?
Yes, that is a common question that we try to answer. For instance, if you are on twice a day medication,
right,
and for instance, you miss your evening medication, we are not saying that in the morning when you do remember, take double. Continue. So take the morning and then in the following evening you take the current dose. So there's a tendency that if you're on twice daily dosing medication and you miss your morning medication, you come in the evening, then you say, oh, I missed the morning, so then let me take double of what I take the actual what I should have taken in the day. No, what we encourage or what we teach is do take just the evening. If you miss the morning, take the evening.
Continue.
And then continue.
Right.
Because if you double, these anti-seizure medications can have a lot of side effects. So
Right.
then you have a risk of having side effects for a drug that was working for you.
Okay. Right. So again, with that, for example, a day or a dose is not a big deal. You just continue.
Yes, exactly.
Right. One of the things I wanted to bring up, Prof, is that we hear we in the management that you are encouraged to note down, keep a record of your seizures as and when they do occur, and the kind of features. Right. How is this helpful in managing the seizures?
Exactly. The features of the seizures help the healthcare practitioner to identify the type of epilepsy you may have. If it's just a focal type or it's just a generalized type. I think last week we talked about the two types. And so that's very important. So if I'm treating you with certain medication and, for instance, you are still having seizures and you come back and you tell me that these are the features you are having. Every morning you wake up, for instance, you're having jerks. And then sometimes you just go off briefly.
Okay.
And then occasionally you may have these convulsions. If I get those features from you, it helps me to, link the type of medication. Because certain medications can worsen certain types of seizures.
Okay.
So that's very important on that angle. And then if you are keeping a seizure diary, and that's describing the type of seizures you're having as well as the frequency at which it's occurring, between yourself and me, your healthcare practitioner, you will be able to see that medication A, when you started, you were still having 10 seizures.
Okay.
When I increase medication A to concentration B, the 10 has gone to maybe 8. But maybe the increased dose we are at a higher dose where if we push it further, we may tip you into developing drug side effects.
Okay.
We can introduce medication, B.
Right.
And that medication B, we notice that maybe you have moved from 8 now to maybe 2.
Joy 99.7.
And it's obvious that medication B has had an effect.
Direct effect.
So between yourself and myself, we can decide to increase medication B and stop medication A. Because the medication B has had a obvious effect. So those are the reasons why we encourage these seizure diaries.
Keeping record.
Keeping records.
Get the features, and then we can tie those to the medication you are on.
Exactly.
And changes that take place.
Exactly.
Be they positive or negative changes.
Exactly.
Okay. 37 minutes past the hour on Joy 99.7 FM. This is getting very interesting. So you realize that it's not Lotto. Maybe the running mate is doing better than the flag bearer, or the parliamentary candidate is doing better, and you can measure using your polls. So this is what Prof is saying in the studio, that they know what they are doing with the medications. They have certain projections or expectations when they put you on medication, but your information is critical in figuring out what happens when you're not in front of your professional or provider in the consulting room, right? And you bring all these data sets together to arrive at conclusive goals and decisions with regard to the treatment and management of your condition. My phone line is still active, 030-221-6541. If you have any questions, experiences, especially if you're living with the condition or the disease, share with us. How has it been? And there's a lot of emphasis on improving your quality of life and actually, should I say, proving that you are capable of living a good quality life despite the condition. That's really the objective here. You're still on Joy 99.7 FM. The program is Ultimate Health.
So in addition, I think we talk about keeping the seizure diary. The timing of the seizures too are very important.
Right. When do they occur?
Yes, when they occur. There are certain people that their seizures do occur only at nighttime seizures.
Okay.
And we get to know that there are certain types of seizures that are classified as occurring at night. And some people, it occurs on awakening. So we know that there are seizures that occur on awakening. And as you know, a lot of people get scared when the seizures occur only at night. But the healthcare practitioners do know that there are certain types of seizures that occur mainly only at night.
Right.
And in that situation, we will know how to get the medication through. We will know whether to add a nighttime medication that you only use at night rather than be adding it to your day dose.
Okay.
So those are very important things that we need to help
Right.
manage you very well,
Okay.
and that kind of thing.
Right, Prof. Can I have a seizure? Can I experience a seizure in my sleep?
Oh, exactly. Seizures can occur in sleep.
Right.
Exactly, because the human brain as it sleeps goes through phases, because we have stages of
Stages
sleep,
of sleep.
stage 1 through to stage 4, and what we
Exactly.
call REM sleep. At the stage 3 and 4 sleep, which is deep sleep,
sleep.
the brain is calm. But when the brain is moving from to the REM sleep, the brain gets a bit active
Yeah.
and irrational. And during that stage, if you have a tendency, you can have a seizure at that time.
Okay.
And REM sleep, we go through several cycles, from a little cycle the moment we get to sleep to a longer cycle deep into the night, 2 a.m. to 4 a.m. So those things do occur. So we can have night seizures only.
Seizures
And,
during your sleep.
yeah.
Now, it's interesting, but when you mention seizures during the night, is it the time of day? Is it what the brain is doing at the time? What makes it, should I say, a time of interest for you, the neurologist? What really changes between daytime and nighttime for the brain? Is there any change when we say we know seizures can occur at night? Is it because we are resting? Is it because we're less active?
Not necessarily. It has to do a lot of physiology, really.
Okay.
The way the body and the brain function.
Okay.
So that's all really. But we have types of epilepsy or seizures that are described to occur only at night.
Okay.
And they can be quite stressful to see, because they are very dramatic motor related, where they put up all sorts of movements
Twitching
and
and jerking and
yes,
all that.
and we know that they are sensitive to certain type of medications,
Okay.
certain lifestyle adjustments, and that kind of thing.
Right. Related to this, many people relate and perhaps attribute seizures to things like stress, lack of sleep, and so on and so forth. Would these triggers be masked, or should I say addressed by medication? If I'm likely to get a seizure if I haven't slept well or if I'm under stress, would medication cover that?
Stress is quite all over the place.
Right.
There are several forms of it, and what we know is that stress is a trigger.
Okay.
So any form of stress you go through can trigger a seizure, and that one is difficult to use anti-seizure medications to control your stress.
Okay.
The stress has to be managed, and you are best placed to manage the stress
Right.
yourself, Nortey.
From behind behind the microphone.
From behind the microphone.
Right.
So it's not always recommended that a person going through stress should be given antidepressants. Really, that's not what we do
Okay.
or we encourage. There are certain stresses that they go through a process
You have
of,
to learn to manage the
Yes,
stresses,
yes,
and
yes.
then you should see.
and that should reduce seizures if you are known to have stress-induced seizures.
Right.
And then we talked about lack of sleep. Lack of sleep, it's known to cause certain to be a trigger for seizures.
Okay.
And the lack of sleep, we are not talking about having sleeping at 12 o'clock and waking up at 6, really, because we encourage 6 to 8 hours of sleep
Right.
regularly. So if you sleep at 12 and wake up
Even for professors.
sleeping at 12 and waking up at 6, but
Right.
so we encourage 6 to 8 hours. So
Okay.
you need that time to have for the brain to have a good, what we call a good sleep hygiene.
Okay.
So those are some, and there are children too that have games that
Right.
trigger seizures, and these
Right.
things are known that, and
The lights, the screen time.
exactly. So
Okay.
if I have a patient whose mother or father or carer tells me that anytime he or she is having playing the games,
Right.
gets seizures, there are certain types of seizures that are age related, and then they grow out of it.
Okay.
So in certain situations, I may not necessarily prescribe anticonvulsants for that patient.
Right.
What I may do is educate the mother, the father, the carer.
Lifestyle behavioral
Exactly,
modifications.
because I
Right.
know that after a certain age, those seizures goes away,
Okay.
never to come back.
Right.
It's
Okay.
age-related and specific.
This is fascinating. But Prof, let me pin it down further, because we've been told, we've learned from you, right, and your colleagues, unprovoked excessive brain activity, right? That's what we're talking about. In this instance where the trigger or the causative agent, if I can call it that, is stress and so many other things, would we then call it a seizure?
Okay.
Because we do hear of pseudo seizures.
Okay.
And would we be able to find evidence of it when we do some of our imaging and so on and so forth in this instance?
Okay. So we want to separate the trigger.
Uh-huh.
The trigger is not necessarily a cause.
It's not okay.
The cause is the underlying problem,
Condition.
underlying condition you
Okay.
have. But the trigger is a situation in which if you find yourself in, would increase
You're more likely.
the
Right.
seizure
Okay.
to occur, really. But then you already have your underlying propensity to develop the seizure.
Okay.
I hope that one is...
That makes it clear.
yeah.
So if you have that underlying diathesis,
yes.
right, it's latent, it's hiding
Yes,
there,
yes.
waiting to be activated or
Yes,
downloaded,
yes.
right,
Yes.
then you have a condition.
Yes. So I mentioned something last week about...
Joy.
or maybe it was Fifi. Epileptic seizures and non-epileptic seizures.
Exactly.
So the non-epileptic seizures are huge.
Right.
And under that we have the pseudo seizures. The pseudo seizures may be more related to
99.7
the simplest way to put pseudo seizures are more seizures that people do for gain, really. The best one described in literature is about a French neurologist called Charcot. So he had
Jean Charcot.
exactly he had a patient. No offense, he had a female nurse who admired him. So anytime he saw him on ward rounds, she would go into a fit,
Whoa.
such that it will be directed such that he has to hold her.
Right. So the gain is the contact and the attention.
The gain is the contact and attention. And
All right.
those have been described. Those are some of the pseudo seizures. These are
Right.
non-epileptic
Okay.
seizures. And then we do have things that people may have heart conditions, that a heart condition may have a transient decreased flow of blood into the brain that may result in a seizure. And we can describe those two as non-epileptic seizures, really.
Okay.
Because if the heart was functioning well and the blood was being pumped well, it's not likely to happen. And so those ones when you have that, what you do is correct the heart problem, and
Right.
then those persons don't have the seizures.
Okay.
So we do have those non-epileptic seizure, and one of the reasons too that we want to have an epilepsy diary for you to keep and record to us, and sometimes videos of the episodes,
Right.
is to be able to put it all in perspective that these are true seizures
Okay.
versus non-epileptic
Non-epileptic
seizures. Yeah.
But they are seizures nevertheless.
Nevertheless,
Okay.
yes. But they are not epilepsy seizures.
Right.
So I won't diagnose you to have epilepsy
Aha.
at that IT.
Wow, fascinating, right? Because we work together and we get a lot of our clients very confused and should I say maybe even at points in time argumentative about these things, that I don't think it is this, it is that, I went abroad, they said this and that and that, and we've handled quite a lot of these things that
Exactly.
challenge the professionals at work, but can be well explained. Right?
Exactly,
And
yes.
another important thing that came out last week is that 50% of these unprovoked electrical, should I say, gymnastics that the brain does have no known cause.
Yes.
Or the cause cannot be identified.
Yes, the cause are not identified at the current level of science and knowledge that we do have. But
Okay.
we do believe that as we go further into neuroscience,
Right.
many of these things will come up.
Okie doke.
Because that's where we got to know through neuroscience studies that many of the genetics of epilepsy doesn't follow simple Mendelian genetics. I said it yesterday, last week, sickle cell. My mother has it, my father has it, has a trait. I'll develop it. Right. So that what it's a de novo. As a baby is born or the fetus is growing, the fetus develop that abnormal gene that leads to the abnormal protein that leads to the abnormal tendency to have seizures.
All right.
So those are some of the little things.
Okay. Right. 50 minutes past your have to go about 10 minutes. Vagus nerve and other forms of cranial or brain stimulation as treatments, Prof. Are we using them here? Are they available here?
No, they are not available. The cost is a bit high for many of our people.
Just briefly, what are we doing in those modalities?
So it is the name. There's a nerve called the vagal nerve. It's a very important nerve in our nervous system.
Okay.
It is the main nerve that helps us to talk. Mm-hmm. It's the main nerve that controls the movement of our gut.
Right.
But how we use it to control seizures is when you stimulate that nerve, it creates some electrical potential on the brain that tends to damp it a bit. Mm-hmm. And that's exactly how it works. So it is done by tracking a little wire through the skin, through the neck to the vagal nerve, which is somewhere around the jaw neck junction there, a little wire, and then it has a stimulator stuck on your chest, and then you have
a bit like a pacemaker.
Exactly. So then you have the stimulator on your wrist that you wear. So it's very good for patients that have a sensation that they are getting their seizures.
Those who get an aura, some kind of
but they usually will be on 2 or 3 medications and still having seizures. So when they get that sensation, they just touch the thing, it stimulates them, gives them like a shock like that, and then it slows it down.
I have an aura from Abdeku that I have a caller on the line. Hello, good afternoon.
Hello, good afternoon, Nortey.
Yes, who am I speaking to?
You are speaking to
Jifa. All right, share with us.
Yes. Please, thank you for hosting this program. I would like to ask 2 quick questions. Could you please tell me the difference between epilepsy and convulsion? And my second question is, at what age does children grow out of that? And finally, can a child with such a condition grow and experience such things again?
Okay.
Thank you.
So just a second, Jifa, when you say at what age does a child grow out of it, are you referring to convulsions? Because you're asking for a distinction.
Convulsion, because my daughter, when she was 4, she started experiencing convulsion. I don't know, foamy stuff comes out of the mouth. At first, I didn't know, so I used to put, when it comes, before I take her to the hospital, I put spoon, a plastic spoon, but today I've been educated. We've been the hospital up and down, but they told me when she's 7 years, she will grow out of it. Now she's 9. When it was 7 years, she grew out of it. She doesn't have episodes anymore. She's 9 years by God's grace. I don't know whether while she grows, a stage will come that she may experience again. That's why I'm asking that.
Okay. Right. Great stuff. Right. And welcome aboard, Jifa. You missed some stuff last week and maybe earlier episodes. So we'll enroll you as a descending listener. But Prof, she's asking about convulsions and epilepsy, right? We did distinguish them, but can we quickly do that? And then she's asking about her child who had these, and then she's been told that the child should grow out of these.
Oh yes, but it's good. She said the child is 9 years and is not having seizures again, which is really good for her. Right. The convulsion, like last week we were trying to say, is a type of seizure. It is a type of seizure that is more common, where we see your hands and your arms being thrown away all over the place, and then you are jerking and shaking. That's a convulsion. In our term, we call it the generalized tonic-clonic seizures.
Okay.
But we have what we call febrile convulsion, which typically, when a child up to the age of from 6 months to 6 years has these fevers, has a fever of any type, malaria, high temperature, then gets a convulsion. And that is what we call a febrile convulsion.
Okay.
And then you are going to hear that a lot. And it happens. Children up to 6 years, 7 years, 8 years, then it goes away.
Right.
And febrile convulsions, unless it is a type of febrile convulsion, what we call complex febrile convulsion, it can lead to seizures later on in life.
Okay.
And the febrile, complex febrile convulsion or seizures, they don't usually happen with the generalized jerk, by shaking. It may be just fever and one arm will be shaking violently and that kind of thing.
Okay.
So those are the things that can lead to future seizures. So if the child was there with febrile convulsion, it is likely that he or she will grow out of it. And there are so many explanations to it, that the child's brain, as it is still rewiring, has a lot of loose ends, and so if it's challenged enough, it can develop a seizure.
Okay.
And yes, so that's what they can grow out of it. And so I mentioned the video game seizures, and these video game seizures, many children grow out of it.
Okay.
And it's usually by the time they are 12 years, 13 years, they stop having these video game seizures.
Okay.
And they might not have it or use it
Do you
again.
think these gadgets and games should come with some kind of health-related warning?
No, I think it is stated in when you buy it. So it's one of it's in the small print.
Right.
It's in the small print, yeah.
Right, because we don't hit on them
Yeah,
hard enough.
Yeah, it's in the small print.
Right. Okay. Right. We've got about 4 minutes, but we've done so much work that I'm wondering. It's starting to feel as if the clock is not moving today, but that's because of who I have in the seat. I'm speaking with Professor Patrick Ajay, Professor of Neurology with the Kolebu Teaching Hospital and University of Ghana Medical School. We're looking at unmasking epilepsy. I'm wondering how much of the mask is left, right? But of course, we're doing our best. Surgery. Now, I saw a video on YouTube that looks at this last, or should I say more downstream option, where we have these seizures that are resistant to the interventions or the modalities that we talked about. Surgical intervention. And in the video, they used something that looked like a mango or a fruit, and then using a spoon to scoop out some of the stuff, mushy stuff, and take it away. When we intervene surgically to control or manage seizures, is that what we're doing? Are we taking out brain matter?
To some extent, yes, and largely yes too, because when we are doing that, where we describe the an area of the brain where the seizure is arising from.
Okay.
We say it's a brain disease. It's something to do with the brain.
Okay.
And the gentleman will talk about brain tumor, where they remove the brain tumor and that kind of thing. So it is removing a section of the brain where the seizure is coming from.
Okay.
And usually these are brain lesions. I'm sure you mentioned something like AVMs, cavernomas. These are all little things that can lead to issues within the brain substance itself, such that if there are sources of seizures and they are identified, they can go through a process leading to epilepsy surgery, and the abnormal area will be removed.
Wow.
We said that the brain is a network of nerves. So you realize that if there's a network of nerves and one of the nerves is damaged because of anything, it means that nerve, the network that it is involved with, is an abnormal network that can be a source of seizures.
Okay.
So then you may not be able to just remove that single nerve, but you may have to map out the whole damaged area.
Okay.
Or abnormal network area and remove it, such that the other areas where the network is not damaged is functional. But the catch here is, if you remove a section of the brain and you cut out the brain, the scarred area can still be a source of
collateral damage.
Yes, it can still be, but it's not like if it happens you get seizures. But the thing is, you may be having so many bad seizures from that damaged area. If it is removed, maybe the seizure that you may have from the scar can be controlled or managed. So even if you have a post epilepsy surgery, it is to reduce the number of or the frequency of the seizures, and to not necessarily to stop the medications.
Right. So you probably would be on medication.
You probably could be on medication
after that surgery.
Yes. And some people can become seizure free, and then over a period may have to come off medications. Okay. I think it was epilepsy surgery that led to the concept of open brain surgeries, really, because you're able to map out, if you're working on the eloquent areas of the brain, where it includes where allows us to talk, move our hands, and that kind of thing.
Yeah.
So the surgeons go through the process where they don't put you to sleep completely, but then they are working on your brain.
We covered one of those with the Ridge Hospital.
Exactly.
Team.
So so because they want to really see that the part they are removing is not going to affect your function.
Right.
It's quite a very interesting form of brain surgery.
Okay.
And the neurosurgeons do it. And
the
neurosurgeons
will be handling that.
Yeah, but it's highly technical. You need to go through the processes of identifying the damaged area, and it involves what we call video telemetry, video EEG telemetry. We mentioned EEGs, but these are observing somebody in a hospital room, seeing the kind of seizures they have, and then mapping it out. And then sometimes even involve open brain EEGs, where the EEG electrode is put on your brain substance itself to really see that it is really coming from this part of the brain. Because you want to be as specific as much as possible.
Right.
It's quite technical, but I think the Indian subcontinent, they were able to do some brain surgeries without all the sophistication, and it helped improve their when they started brain surgery, epilepsy surgery. They did it with minimal sophistication, which worked for them.
Right. So this is also a treatment or management modality that is available here.
Exactly. Epilepsy surgery.
Yeah.
Not yet.
Not yet.
Yes.
Okay.
We are working hard to get it in here with the KOICA.
Right.
Korean International Cooperation Agency.
Okay.
We are working hard to try and get that surgery here.
Prof, this has been so educative, and we didn't even notice we've gone past 3 o'clock. But this has been very, very fascinating, and we've shed a lot of light on epilepsy. I want to give a minute or so, because there's a lot of misinformation, stigma, discrimination. We work hard to break down the walls of stigma and discrimination, but what's your comment on this? Me, I work in mental health, you work in neurology, but there's a lot of misinformation. How do we beat that? Apart from doing programs like this, what else should we be doing?
I think we should keep the education on, and all the healthcare practitioners are encouraged to educate their patients on epilepsy.
Okay.
So once you pick a case of epilepsy, you should be able to educate the patient itself, educate the patient's relative on the condition, the fact that it is not a disease of contagion, it is not a spiritual disease. It is a disease that affects the brain. And once it affects the brain, any person can have epilepsy.
Right.
It is similar in this context to diabetes, mellitus, and or even hypertension for that matter, because anyone can develop it. So in that situation, we educate our patients on that angle, and let them know that we have medications, just as we have for hypertension, to treat. So it is the education of the patient, the affected person's relatives, that would keep the epilepsy out of the shadows and help reduce the stigma. It is always about the education.
Right.
It is always about the education, but it's a disease that has had its roots in spiritualism for years. I think the Romans described them as lunatics.
Yeah.
And I think in the Middle Ages they were called the fallen sickness. But we have moved from those historical events.
A lot of advancement in medical knowledge
to the modern world, and people have come to realize that anyone can have a seizure, and anyone can be diagnosed to have epilepsy, and there is treatment for it. When you go on the net, there are several big people, several international people who might have had epilepsy or seizures who are on medication and they are doing what they have to do.
Right.
We always encourage that epilepsy shouldn't be a disease that affects you from doing whatever you have to do. You should do everything or whatever you want to do.
Okay. Great stuff. You heard that from Professor Patrick Ajay, an associate professor in neurology, consultant neurologist with the Kolebu Teaching Hospital, and of course the University of Ghana Medical School. We'll continue our education series on brain conditions, brain disorders, and brain function in partnership with the Neurology Society of Ghana. Stick and stay on Joy 99.7 FM. Many thanks to my discerning listeners and, of course, my producer, Abeku-san Kofi. Talking about seizures, it looks like in the Premier League, some things are happening. Abeku, am I right? Is this a full-time score? Chelsea 6, Wolves 2. Wow. All right, things are happening in the Premier League. Stick and stay on Joy 99.7 FM. My name is Nortey by nature, produced by Abeku-san Kofi. Many thanks to you. Catch up with you on the flip side next Sunday. Stick and stay.